എല്ലാ വിങ്ങുകളെയും ഞാൻ ആദ്യമായി അഭിനന്ദിക്കുന്നു. പ്രസിഡന്റ്, സെക്രട്ടറി എല്ലാവരെയും. കാരണം ഇതൊരു ടീം വർക്കിന്റെ എഫർട്ടാണ്. അതിനെ എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. രണ്ടാമത്തെ കാര്യം, ഞാൻ വിങ്ങുകളായിട്ട് ഞാൻ ആദ്യമായി അഭിനന്ദിക്കുന്നു. പ്രസിഡന്റ്, സെക്രട്ടറി എല്ലാവരെയും. കാരണം ഇതൊരു ടീം വർക്കിന്റെ എഫർട്ടാണ്. അതിനെ എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. ഹലോ. രണ്ടാമത്തെ കാര്യം, വിങ്ങുകളായിട്ട് ഞാൻ ആദ്യമായി അഭിനന്ദിക്കുന്നു.
എക്സ്ക്യൂസ് മീ ഗോപി സാർ, ഒരു സെക്കൻഡ് ഒന്ന് സ്റ്റോപ്പ് ചെയ്യണം, ഒന്ന് ഇന്ററപ്റ്റ് ചെയ്തോട്ടെ, സോറി. ജോയ് സാർ യൂട്യൂബിന്റെ വീഡിയോ ഓഡിയോ ഒന്ന് മ്യൂട്ട് ചെയ്യണം, ഇല്ലെങ്കിൽ എക്കോ ഇട്ട് കേട്ടോണ്ടിരിക്കും. യൂട്യൂബിന്റെ ഓഡിയോ മ്യൂട്ട് ചെയ്യണം. എക്സ്ക്യൂസ് മീ ഗോപി സാർ, ഒരു മിനിറ്റ് ഒന്ന് ഇന്ററപ്റ്റ് ചെയ്തോട്ടെ, സോറി. ജോയ് സാർ യൂട്യൂബിന്റെ വീഡിയോ ഓഡിയോ ഒന്ന് മ്യൂട്ട് ചെയ്യണം, ഇല്ലെങ്കിൽ എക്കോ ഇട്ട് കേട്ടോണ്ടിരിക്കും. യൂട്യൂബിന്റെ ഓഡിയോ മ്യൂട്ട് ചെയ്യണം.
ഞാൻ പ്രസംഗിക്കുന്നതൊക്കെ തിരിച്ചു
ഗോപി സാർ കണ്ടിന്യൂ ചെയ്തോ.
ഓക്കെ, ഇപ്പൊ ശരിയായിട്ടുണ്ട്. ഓക്കെ, അഭിനന്ദനങ്ങൾക്ക് ശേഷം ഞാൻ രണ്ട് കാര്യങ്ങൾ പറയാനായിട്ട് ആഗ്രഹിക്കുന്നു. ഒന്ന്, രാജഗോപാൽ സാറ് ചോദിച്ച പോലെ തന്നെ ആ വാക്സിന്റെ കാര്യമാണ്. വാക്സിൻ ഇപ്പോ എല്ലാ മോഡേൺ മെഡിസിൻ ഡോക്ടർമാർക്കും മറ്റ് ഹെൽത്ത് കെയർ വർക്കേഴ്സിനും ഇൻസ്റ്റിറ്റ്യൂഷൻ അറ്റാച്ച്ഡ് ആയിട്ടുള്ള എല്ലാ ഹെൽത്ത് കെയർ വർക്കേഴ്സിനും ഇൻക്ലൂഡിങ് മിനിസ്റ്റീരിയൽ സ്റ്റാഫിനാണ് ഇപ്പോൾ ഡാറ്റാബേസ് ക്രിയേറ്റ് ചെയ്തുകൊണ്ടിരിക്കുന്നത്. അതിൽ ഇന്ന് ഞാനൊരു പോസ്റ്റ് വാട്സാപ്പിൽ ഇട്ടിട്ടുണ്ടായിരുന്നു. അതിനകത്ത് ഇതുവരെ ഉള്ള സ്റ്റാറ്റസ് പറഞ്ഞുകൊണ്ട് അതിനകത്ത് ഇനിയും കൂടുതൽ പേര് അപ്ലോഡ് ചെയ്യാനുണ്ട്. അത് എത്രയും പെട്ടെന്ന് ചേർക്കണം എന്ന് ഉള്ളൊരു അഭ്യർത്ഥനയുണ്ട്. ഒന്ന്. രണ്ടാമത്, ഇപ്പൊ ആദ്യമായിട്ട് ഇത് നാഷണൽ ഗവൺമെന്റിന്റെ ഡയറക്ഷൻ അനുസരിച്ച് ചെയ്യുന്നതാണ്. ആദ്യമായിട്ട് ഹെൽത്ത് കെയർ വർക്കേഴ്സിനാണ് പ്രയോറിറ്റി. അത് കഴിഞ്ഞിട്ട് പിന്നെ ഹൈ റിസ്ക് ഗ്രൂപ്പ്, എസ്പെഷ്യലി റിവേഴ്സ് ക്വാറന്റൈൻ ഗ്രൂപ്പ്, അങ്ങനെ അതങ്ങനെ വന്നുകൊണ്ടിരിക്കും. അപ്പൊ ഇതില് ഹെൽത്ത് കെയർ വർക്കേഴ്സിന്റെ മാതിരി അവസാനിച്ചതിന് ശേഷമായിരിക്കും, അല്ലെങ്കിൽ നല്ലൊരു ശതമാനം ചേർന്നതിന് ശേഷമായിരിക്കും അടുത്ത് തുടങ്ങുന്നതെന്ന് മനസ്സിലാക്കുന്നു. മൂന്നാമത്തെ കാര്യം, ഇപ്പോ കഴിഞ്ഞ 15-ാം തീയതി പുതിയ ഭാരവാഹികൾ ചാർജ് എടുത്തു. ഡോക്ടർ പി.ടി. സക്കറിയ സ്റ്റേറ്റ് പ്രസിഡന്റായി. ഞാനിപ്പോ തിരുവനന്തപുരത്തേക്ക് പോയിക്കൊണ്ടിരിക്കുകയാണ്. നാളെ അദ്ദേഹം IMA ഹെഡ്ക്വാർട്ടേഴ്സിൽ അധികാരം ഏറ്റെടുക്കുകയാണ്. അതിനായിട്ട് ആണ് നിങ്ങളൊക്കെ പോകുന്നത്. എല്ലാവരുടെയും ഈ വർഷം എല്ലാ ബ്രാഞ്ച് അംഗങ്ങളുടെയും എല്ലാ ബ്രാഞ്ചുകളുടെയും സഹകരണം ഉണ്ടാകണം എന്നുള്ള അഭ്യർത്ഥനയാണ് എനിക്ക് മുന്നോട്ട് വയ്ക്കാനുള്ളത്. പ്രധാനമായും പുതിയ പ്രസിഡന്റിന്റെ ഏറ്റവും പ്രധാനപ്പെട്ട അജണ്ട മെമ്പർഷിപ്പ് കൂട്ടുക എന്നുള്ളതാണ്. പുള്ളി എയിം ചെയ്തിരിക്കുന്നത് ഡബിളിംഗ് ദ മെമ്പർഷിപ്പ് ആണ്. ഇന്ന് നമുക്ക് 33,000-അടുത്താണ് ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷൻ കേരള സ്റ്റേറ്റ് ബ്രാഞ്ചിന്റെ അംഗസംഖ്യ. അത് ഇരട്ടിയാക്കണം എന്നുള്ള ദൗത്യമാണ് പ്രസിഡന്റ് മുന്നോട്ട് വച്ചിരിക്കുന്നത്. എല്ലാവരും ഒത്തൊരുമിച്ച് ശ്രമിച്ചാൽ ഇതിന് സാധിക്കുമെന്ന് തന്നെയാണ് നമ്മൾ വിശ്വസിക്കുന്നത്. അതുകൊണ്ട് തന്നെ ആ ഒരു രീതിയിലേക്ക്, ആ ഒരു തലത്തിലേക്കും കൂടെ നമുക്ക് പ്രവർത്തനങ്ങൾ കൊണ്ടുപോകേണ്ടതുണ്ട്. അതുപോലെ തന്നെ മെമ്പർഷിപ്പ് സ്കീമുകളിലെ മെമ്പർഷിപ്പ് കൂടാതെ സ്കീമുകളിൽ, പ്രത്യേകിച്ച് സോഷ്യൽ സെക്യൂരിറ്റി സ്കീമുകളിൽ ചില ബൈലോ അമെൻമെന്റ്സ് വന്നിട്ടുണ്ട്. വളരെക്കാലത്തെ ആവശ്യത്തിന്റെ ഫലമായി പലരുടെയും പല അംഗങ്ങളും ആവശ്യപ്പെട്ടതനുസരിച്ച് സോഷ്യൽ സെക്യൂരിറ്റി സ്കീമിൽ നിന്ന് മരണാനന്തരം മാത്രം കിട്ടിക്കൊണ്ടിരുന്ന ജീവിച്ചിരിക്കുമ്പോൾ തന്നെ കിട്ടാനുള്ള ചില ക്ലോസസ് ആഡ് ചെയ്തുകൊണ്ട് പുതിയ ബൈലോ അമെൻമെന്റ് വന്നിരിക്കുകയാണ്. ജനുവരി 1 മുതൽ അത് പ്രാബല്യത്തിൽ വരും. അതനുസരിച്ച് സോഷ്യൽ സെക്യൂരിറ്റി സ്കീം 1-ൽ നിന്ന് 20% തുകയും 2-ൽ നിന്ന് 30% തുകയും, അതുപോലെ സോഷ്യൽ സെക്യൂരിറ്റി സ്കീമിൽ 3-ൽ നിന്ന് 50% തുകയും വരെ അത്യാവശ്യമെന്നല്ല, ഒരു ഡിസബിലിറ്റി ക്ലോസ് അനുസരിച്ച് മെമ്പർക്ക് കിട്ടുന്നതിനായിട്ടുള്ള ഒരു അമെൻമെന്റ് ആണ് വരുത്തിയിരിക്കുന്നത്. പക്ഷെ ഒന്ന് നാം ഓർക്കണം, ഈ സോഷ്യൽ സെക്യൂരിറ്റി സ്കീമിന്റെ രീതി അനുസരിച്ച് ഒരാൾ മരിച്ചു കഴിഞ്ഞതിന് ശേഷം മാത്രമേ അയാൾക്ക് ആ മെമ്പർക്ക് കൊടുക്കാനുള്ള ഫ്രട്ടേണിറ്റി കോൺട്രിബ്യൂഷൻ നമുക്ക് കളക്ട് ചെയ്യാൻ സാധിക്കുള്ളൂ. അപ്പോ ഇതുപോലെ ഒരു ഡിസബിലിറ്റി ക്ലോസ് അല്ലെങ്കിൽ ഡിസബിലിറ്റിക്ക് ആയിട്ട് നമ്മളൊരു എമൗണ്ട് കൊടുക്കുമ്പോൾ ആ കൊല്ലത്തിൽ ആ കൊല്ലം അദ്ദേഹത്തിന്റെ ആ മെമ്പർഷിപ്പ് ടെർമിനേറ്റഡ് ആവുകയും ബാക്കി ആ ദിവസം കിട്ടാവുന്ന മൊത്തം ഫ്രട്ടേണിറ്റി എമൗണ്ടിലെ ബാക്കി വിഹിതം സ്കീമിൽ തന്നെ സൂക്ഷിച്ചുകൊണ്ട് അദ്ദേഹത്തിന് മരണാനന്തരം ഫാമിലിക്ക് കൊടുക്കുന്നതും ആയിരിക്കും. ആ രീതിയിലാണ് അത് വിഭാവനം ചെയ്തിട്ടുള്ളത്. പക്ഷെ പലരുടെയും പല ഭാഗത്തു നിന്നും ഉണ്ടായിരുന്ന ആവശ്യങ്ങളും നിരന്തരമായ ആവശ്യങ്ങൾ അനുസരിച്ചാണ് ഇത്തരത്തിലൊരു അമെന്റ്മെന്റ് സ്കീമിന്റെ റിഫോംസ് കമ്മിറ്റി ചെയ്തിട്ടുള്ളത്. ഇത് സ്കീം 1, 2, 3 വരും. മൂന്നാമത്തെ മറ്റൊരു കാര്യമുള്ളത്, പ്രൊഫഷണൽ പ്രൊട്ടക്ഷൻ സ്കീമില്
പറയുന്നത് കേൾക്കുന്നില്ല കേട്ടോ. ഡോക്ടർ ഗോപി മ്യൂട്ട് ആയിട്ടാ, അൺമ്യൂട്ട് ചെയ്യണേ.
ഇപ്പൊ കേൾക്കാവോ?
കേക്കാം.
അപ്പൊ ഏതായാലും പുതിയൊരു വർഷം ആരംഭിക്കുന്നു. അതിന്റെ ഈ വർഷത്തിന്റെയും ഒരു പകുതി ഭാഗം കോവിഡ് പ്രോട്ടോകോൾ അനുസരിച്ച് തന്നെ പോകേണ്ടി വരാമെന്ന് തോന്നുന്നു. എങ്കിൽ പോലും കൂടുതൽ മെമ്പേഴ്സിനെ ചേർക്കാനും മറ്റുമായിട്ട് നമുക്ക് കൂടുതൽ ഒത്തൊരുമിച്ച് പ്രവർത്തിക്കാം. അതിനെല്ലാവരുടെയും സഹകരണം ഒരിക്കൽ കൂടി അപേക്ഷിച്ചുകൊണ്ട് എല്ലാ ആശംസകളും ഇന്ത്യൻ മെഡിക്കൽ അസോസിയേഷൻ തൃശൂർ ബ്രാഞ്ചിനും അതിന്റെ ടീമിനും നേർന്നുകൊണ്ട് നിർത്തുന്നു. നന്ദി. JMA ജയ് ഹിന്ദ്.
Thank you, Dr. P. Gopi Kumar, for your address. Now I invite Dr. Pawan, Secretary, for the minutes and activity reports. Over to you, Dr. Pawan.
Thank you, Joy sir.
Hello. ഒരു മിനിറ്റ് Pawan. ഒരു മിനിറ്റ്. Dr. Jain, ഞാൻ എപ്പോഴാണ് കാണുന്നത്?
Sorry, even I am traveling. Anyway, I don't have anything much to say. State Secretary ഉള്ളപ്പോൾ ഞാൻ പറഞ്ഞിട്ടുണ്ട്, സാധാരണ ജോയിന്റ് സെക്രട്ടറിക്ക് വലിയ റോളില്ല. എന്നാലും anyway, I take this opportunity to congratulate President for coordinating the activities this year. ഇത് ഭയങ്കര ഒരു ബുദ്ധിമുട്ടുള്ള പണിയാണ്. കാരണം എല്ലാവരെയും അറിയാലോ, നമ്മുടെ മെമ്പർമാരെ ഒരു പരിപാടിക്ക് എത്തിക്കുക എന്നുള്ളത് വലിയൊരു ബുദ്ധിമുട്ടുള്ള പരിപാടിയാണ്. അതുപോലെ തന്നെ എല്ലാ വിങ്ങുകളെയും AMS ആയാലും CGP ആയാലും WDW ആയാലും ഒരു കുടക്കീഴിൽ അടിഞ്ഞു നിർത്തി അവർക്ക് എല്ലാവർക്കും സ്വതന്ത്രമായിട്ട് പ്രവർത്തിക്കാനുള്ള സൗകര്യം ചെയ്തു കൊടുക്കുക. അതുപോലെ തന്നെ അവരെ മാക്സിമം അവരുടെ പെർഫോമൻസിൽ പെർഫോം ചെയ്യാനായിട്ട് എൻകറേജ് ചെയ്യുക എന്നുള്ളതാണ് നമ്മുടെ ജോയ് സാറ് കഴിഞ്ഞ വർഷം ചെയ്തത്. അതിന് അദ്ദേഹത്തെ എത്ര അഭിനന്ദിച്ചാലും മതി വരില്ല. അദ്ദേഹത്തെ ഒന്നുകൂടി ഞാൻ അഭിനന്ദിക്കുകയാണ്. ഈ വർഷവും എല്ലാവിധ ഐശ്വര്യങ്ങളും മംഗളങ്ങളും നന്നായി വരട്ടെ എന്ന് ആശംസിച്ചുകൊണ്ട് നിർത്തും. നന്നായി. താങ്ക് യു.
Okay, now over to you, Pawan. Dr. Pawan. Hello.
കാണാമോ ജോയ് സാറേ?
സ്ക്രീൻ വന്നുകൊണ്ടിരിക്കണല്ലോ. പവൻ IMA Thrissur സ്റ്റാർട്ടഡ് സ്ക്രീൻ ഷെയറിംഗ് കാണിക്കുന്നുണ്ട്.
വിസിബിൾ ആകുമ്പോൾ ഒന്ന് പറയണേ. Joy sir, screen visible alle po?
Okay. Oh, well, visible ആണ്.
Okay. Good evening, everyone. I once again welcome our guest faculties. I promise I will not take much time. I'll just try to finish in 5 to 10 minutes. This is regarding the activities of our branch over the last 1 month. Happy to inform, like already told, we have got the SS Rao Shield for the best branch and Shankarapillai Award for the best secretary, and the second place in AMS and CGP subspecialties. I once again thank our president, Dr. Joy Manila, for leading us for achieving this during the state conference. These are few pictures from the state conference. IMA Thrissur receiving the SS Rao Shield from the state president, Dr. Abraham Varghese. And also you can see the new president, Dr. Zakaria sir, being installed as the president during the meeting. Minutes of the last month general body. We had the installation of our office bearers for 2021 of IMA Thrissur. It was on October 3rd via Zoom, inaugurated by Professor C.P. Vijayan, Pro Vice Chancellor of KUHAS. Dr. Abraham Varghese, President, installed the President, our President, Dr. Joy Manila, and was followed by State Secretary's address by Dr. P. Gopikumar and Joint Secretary Dr. Jane Chiman's address. Dr. Pawan Secretary thanked the gathering, and we had a special event organized by our IMA Cultural Wing. That was a tribute to SP Balasubramaniam, led by Dr. Santosh Babu, Dr. Nivin, and Dr. Arun. Then other activities of October, November. Academic activities we conducted at branch, district, state level, and even at international level. We had a scientific session which was organized by Women's Doctors Wing of IMA Thrissur. It was My Care, My Comfort. Dr. Pei Pari, Chairman of Palliative Care, was the chief guest, and the meeting was conducted as a part of the World Hospice Day. Dr. E. Divagaran, Director, Institute of Palliative Care, gave the keynote address, and we had Dr. Rajeshri and Dr. Sujit as the faculties. Then we had another meeting by the WDW on the International Day of Girl Child. My Voice, Our Youth Equal Future. And our chief guest was Dr. Kavita Ravi, and we honored Dr. Rajalakshmi, convener of Women Doctors Wing, and we had address by State Secretary and Joint Secretary, and we had Dr. Shobana Mohandas and as the faculty, and Dr. Jasna psychologist as a faculty during the meeting, which was moderated by Dr. Kavita Mukesh. Then World Polio Day observation, which was on 24th of October. We had an eminent speaker, Dr. P.N.N. Pisharadi, who is a pediatrician at the District Early Intervention Center at GH Ernakulam. He gave a wonderful talk regarding 2 centuries of vaccine from smallpox to SARS. And we also had our State Secretary, Dr. P. Gopikumar, and Dr. Anandakeshavan, who is the National Vice President of Indian Academy of Pediatrics. They both gave an address during the meeting. Then we took a training session on COVID-19 infection prevention control for the Police Academy, which was the 3rd session. It was a state level, mainly the police people from the Thrissur district and other district also participated. The session was taken by myself and also by Dr. Paurami Mohandas. Then we conducted a very elaborate program on COVID clinical readiness course, which was conducted in association with the Indian Society of Anesthetists. It was IEM Lecturio COVID-19 clinical readiness course, which was certified by International Emergency Medicine. We had adequate participants for the course, and they emphasized on managing sepsis, airway consideration, early symptomatic management of ventilated patients during in a COVID scenario. Then CGP of IMA Thrissur on the World Epilepsy Day on November 17th, organized in association with the Thrissur Neurological Society, organized a meeting on the World Epilepsy Day, and we had Dr. Narayan Unni and Dr. Fiju Chako as the faculty, and they spoke on women with epilepsy and basics and practical approach to epilepsy. Then updates on endovascular therapy of stroke. We took a session on the World Stroke Day, which was organized by the IMA AMS Thrissur, and it was an international CME. The faculties were Dr. Ajit Thomas and Dr. Anil Neelakandan, both from USA. They took the session via Zoom, and Dr. VG Pradeep Kumar gave an introduction, and also Dr. Raghunath from Thrissur, he moderated the session. Then IMA Thrissur observed the World Diabetes Day. We had Dr. P.T. Sakri, our new president, as the chief guest. He inaugurated the event, and the meeting was presented by Dr. Joy Manila. And we had IAP also and NNF also associating with us for the event. So we had Dr. Reddy Shantakumar, Dr. Narayanan, Dr. Manoj, Dr. Balachandran from IAP and NNF side. And we had a special training program. As you all know, the Zumba wing, physical fitness wing of IMA Thrissur is very active. They are regularly conducting Zumba sessions. And on the day of World Diabetes Day, they organized a high-level, high-intensity training program for our members via online, and it was attended by 30 participants. This I have already mentioned regarding the GB. Then women doctors wing, I have already mentioned. We had 2 major events over last month, and this one was the third one organized by IMA Women Doctors Wing of Thrissur, which was the Children's Day celebration. We organized it on 18th. As per our convenience, because of the state conference, we had to shift this program on to 18th, and we had Dr. Kavita Devi inaugurating the function, and we had Dr. Anju Teresa Andrews and Dr. Sam as the faculties during the celebration. They took a CME session, which was very useful for, which was a very interactive session for the members as well as their children. Then the cultural wing was very active over the last 1 month. I already told we had the tribute to SP Balasubramaniam during our general body and installation ceremony last month. And another major event which occurred in the virtual platform was Sankalp 2020. I must say this was a brainchild of Dr. Joy Manila. He took initiative to organize a state level cultural event. We had a virtual platform, and we had a lot of events, including songs, dances, and even Chakyar Kutha during the event, which was streamed from the IMA house. Then regarding current issues, we had a live discussion on rising number of COVID, which was a live program in the Doordarshan. We had Dr. Amar Fettil, who is the state nodal officer of Corona, and we had Dr. Krishnamur, who is the director of Imhance from Kozhikode, and myself attended live from Thrissur, and it was a very useful and interactive session on the COVID scenario in Kerala. It was conducted on October 15th, and it was mainly focusing on rising number of COVID. At that time, we had COVID touching 10,000 plus cases in our state. Then we had a meeting with the central team of observers, which was attended by Dr. Joy. It was conducted in the collector's chamber at Thrissur, and there was a central team visiting, and it was organized on 19th of October. Then there was an emergency meeting of IMA Thrissur, IAP Thrissur, Indian Dental Association, Lab Association, etc., organized by the DM of Thrissur, which was mainly regarding the vaccine database, which we are preparing right now. They asked IMA to cooperate and also to coordinate all the vaccine data from the private hospital and the government sector as well. So according to their request and advice, we are coordinating all the hospitals. We received a lot of calls regarding so many queries regarding filling the data and collecting the data. One major issue in it was regarding the single private practitioners or home practitioners, where they had issue regarding registering in the COVID data sheet, but IMA could intervene, and as of now we have got a reply that we can include all the home practitioners also in the data sheet. But regarding the availability of the vaccine, it will be according to the list prepared by the central government. I would like to say that IMA will not have any hand in selecting the doctors for receiving the vaccine. It will be decided by the government, but we are just coordinating with them for collecting the COVID data. But as you can see in the data list, you can see in most of the district, government have given adequate data, but from the private sector, the participation is very poor. The data sent to the government from the private sector, as you can see in the Thrissur district, is only 9%, and in many districts like in Malappuram, you can see only 3% have sent but in districts like Trivandrum and Kannur, they have reached almost 94-95%. So I think I request all the private hospitals to send the data as early as possible, and there should not be any lag in that, because this is a very serious issue. I request everyone to send the data directly to the email which we have already provided. Then we had a seminar on MSME conducted by Hospital Board of India on 19th. President Dr. Joy Manjula attended the seminar. Then we had a special project for the adolescents called READ, which was organized, and IMA Thrissur is actively participating with the organization for conducting this program. And we already conducted a session in association with them. And during the session, Dr. P. Gopikumar gave a special address from the side of IMA, and Dr. Joy Manjula also participated in the event. Then this is the tele-ICU program. We have been after this, Dr. Joy and myself, we have been after the tele-ICU for over last few months. When the cases were touching around 10,000, there was the DMO and the district administration had requested us to coordinate regarding the tele-ICU initiative in Thrissur. As a part of that, we had organized a CME for the private hospitals mainly. The session was taken by Dr. Dilip Raman. He took a session on tele-ICU, the pandemic scale relevance, and it was well attended. And we are going on with the project, but we are yet to gain all the data, and we will be initiating as per the cooperation from the private hospital side. So this is briefly regarding the activities of the last month. I request Dr. Joy Manjula to take over.
Screen on unmute yet. Screen on the
yes.
Screen share. Okay. Now, thank you, Dr. Pavan, for the elaborate minutes and activity reports. And now I welcome now we will move on to the scientific session. Today's scientific session will be conducted by Apollo Adlex Hospital, Karguti and Gamari. Now I will hand over them for further proceedings. Over to you. Hello, Dr. Julian.
Yeah, so Dr. Binjo and Dr. Julian here. I think Dr. Myers will be doing the first talk, sir. Are you?
Okay, carry on. You are welcome, Dr. Julian. Go ahead.
Dr. Myers.
Can you see the screen?
Start seeing.
Yeah, screen. Yeah.
At the outset, I would thank Dr. Joy Manjula and Dr. Pavan Madhusudan for the opportunity given to this hospital and my team for this talk. I would also congratulate you for having won the shield for the best IMA and for the best secretary. Commendable, because I have seen ethra competition, how much of work people put into make their IMA a big success. Congratulations. So, ഞങ്ങൾ 3 ടോപ്പിക്കായിട്ടാണ് ഡിവൈഡ് ചെയ്തേക്കുന്നത്. I will speak first on the cardiovascular emergencies during COVID era. നമ്മുടെ ഈ the specificities of cardiovascular problems during COVID. So, greetings from Apollo and Adlex. What are the key points which I would like to mention before I go ahead with the talk? The pathobiology of coronavirus infection involves SARS-CoV-2 binding to the host receptor angiotensin converting enzyme to mediate, and that is what mediates entry into the cells. ACE2 is found plenty in the heart and lungs, hence that is the organs through which the virus can find an entry. CVD associated with COVID-19 involves dysregulation of the system because of the COVID infection and already existing comorbidities such as hypertension. It may be a primary phenomenon, may not be the only phenomenon. There is something known as a cytokine release storm. I will tell you what it is and how it works. And immune system activation along with immune metabolism alterations may result in plaque instability, contributing to the development of acute coronary events. So this is a big slide which we can divide into three sections. One is what it does to the 1 second. One is what it does to the coronaries. One is what it does to the myocardium, and what does the cytokine storm do. So if I take the first part, this is what it does to the coronaries. So as I said, through the ACE inhibitors, ACE receptors, they come inside, they come into the coronary artery, involve the endothelial cells, and make it macrovascular endothelial dysfunction, and that results in an acute coronary syndrome. So that is what happens in the coronary artery side of the heart. So acute coronary syndrome, if it is totally occluded, then it becomes an ST elevation MI. If it is partially occluded because of occlusion, lipid deposition, then it becomes a non-ST MI. Even a thrombus can occlude it partially and manifest as non-ST MI. So 2-3 manifestations of the coronary artery involvement in COVID-19 can happen like any other situation where you can have an ST elevation MI or an non-ST elevation MI. So that is called MI type 1, MI type 2. And basically there is going to be a demand requirement, supply reduction, which causes an acute myocardial infarction. Second thing, what it does is the viral invasion causes the macrophages and the immune activation, T cells macrophage immune activation to take place on the myocardium. This causes fulminant myocarditis, causing myocardial damage, and we get what is classically called as a dilated cardiomyopathy of the COVID type. So COVID, this reaction of T cells and macrophages on the causing fulminant myocarditis leads to myocardial damage. Third and the most disastrous thing is the cytokine storm. During the cytokine storm, it's basically overreaction of the body's defense mechanism to the COVID virus that has come inside. The cytokine storm causes plaque instability and acute coronary syndrome. It causes myocardial damage and heart failure, myocarditis and myocardial dysfunction, and can cause heart failure and arrhythmia. So this becomes a very big plethora of events, which is like a tsunami, and we may not be able to get things under control once this issue takes place. So in a large reaction of the body to the COVID virus, you can have a plaque rupture, you can have myocarditis, you can have heart failure, you can have cardiac arrhythmias, and almost irretrievable situation. So we know about the COVID test, antibody test, nucleic acid test, antigen-based immunoassay, and clinical tests. I shall not go into that. What I would like to tell you is about the protection. So we have to be knowing as a cardiologist and as a physician and as an emergency room physician, what is your level 1 protection, level 2 protection, and level 3. Disposable surgical cap, mask, and work uniform with latex gloves is only for pre-examination triage, NSR, or examining a patient who is SARS-CoV-2 negative. Level 2 protection is a disposable surgical cap, medical protection mask, work uniform, gown, disposable surgical gloves, and goggles. Now, level 2 protection is what we use in our cath lab, because that is what we require. And if there is an anesthetist in the cath lab who requires to intubate and who requires to look after the head end of the patient, he requires a level 3 protection. So these levels of protections are very important for the patient, for the doctors who are managing in the cath lab. So you have COVID mask of FFP 3.023 micron, FFP 2.3, N95.3, surgical mask 2 micron, and the powered air purifying respirator, which is available in a few places in Bombay and Delhi, that is basically being used by the anesthetist. So what happens at ER? If there is no COVID, triaging as per standard protocols, NSTMI, STMI, whatever. If the COVID infection is a possibility, then we look at the heart condition. If it is unstable, then we do a screening in the ER and then decide how aggressively we should go. If the condition is not requiring a stable, unstable situation or not demanding an urgent medical help, we consider it as a conservative thing. We wait for the results to come before we tackle this patient. So what does the European Society say? These are the emergency situations where it has been dealt with immediately, urgent situations, low priority, and elective. Elective is postponed for more than 3 months. Lower priority is less than 3 months. Urgent is performed within days. That means you take the patient, do an RT-PCR. If he is negative, then you go ahead with it immediately. Otherwise, you wait for the take all the precautions, level 3 precautions, and do the case. What are the emergencies? ST elevation MI across the board, specifically anterior wall. Don't delay. Non-ST MI with high risk and very high risk patients or in cardiogenic shock, you should treat it as an emergency and take immediately. Valvular heart disease, only a balloon valvotomy in case of a severe AS with failure. In case of acute or chronic heart failure, when mechanical circulatory support is required. In arrhythmia, where there is a pacemaker implantation for an AV block or symptomatic sinus node dysfunction, and others pericardial synthesis and cardiac tamponade. Everything else is to be done with a COVID negative test report in hand. If it is positive, we should take level 2 and level 3 precautions before we take up the patient for the procedure. So again, just to risk stratify, very high risk, intermediate risk, low risk, and then decide as per the flow chart I had explained earlier. So in case of cardiogenic shock, if the shock is if you're having an extremely serious patient in shock with too much of comorbidities, it is like, you have to take it with a pinch of salt. You have to see whether the cost risk benefit ratio in tackling this patient is favorable to the situation or not. So you have to take a balanced call in a very sick patient. Why do patients die? Patients die because of heart involvement. You see, if you see the troponin I levels in patients who did not make it are going up to 290.6 in cases of patients who died because of heart failure. Why? Because of it is type 1 myocardial infarction, myocarditis, Takotsubo cardiomyopathy, or shock. These are the reasons why the patients don't do well, and these are the reasons why the troponin levels are very high in such patients. And third point I would like to stress is something very peculiar to the COVID patients. If you have a COVID patient who underwent primary angioplasty, you'll find cardiac resuscitation is required in as high as 42%, mechanical ventilation in 42%, death in 26%, hypotension requiring anotropes. So most of the things except hemorrhagic stroke, rest, everything is extremely high in ST elevation MI patients who underwent primary PCI. Same time, if you did thrombolytic therapy for these patients, you will find hypertension is only 10%, cardiac resuscitation 9%, mechanical ventilation 10%, death is 7%, but hemorrhagic strokes are high. So if it is not a patient who is anterior wall MI or an MI involving a very large territory, thrombolysis may be even equal to, if not better than, an invasive strategy in a established COVID positive patient. So this is the summary of what I just said. 21% risk rate higher in PCI as compared to thrombolysis. What is the recommendation as a result of this? What I've got to say is that you have to have, if the patient comes to a primary care center, you have to have a reperfusion therapy and healthcare providers' health and safety. So we have to balance between salvaging the patient's myocardium and not getting the hospital and the whole department down with COVID. So if the hospital has got PCI capability and the patient is okay, is hemodynamically stable, has got a lateral wall MI or has got a posterior wall MI, you may go ahead and administer fibrinolytic therapy. If the patient has got hemodynamic significance or a complete heart block with inferior wall MI or a significant anterior wall MI, go ahead and take him for a primary angioplasty. If you are a peripheral hospital where the patient has come to you, the natural tendency is to shift to a hospital with PCI. In these cases, if there is a low risk strategy, if the patients of the lower risk strata of acute myocardial infarction, kindly thrombolyze in your own hospital. And if post thrombolysis there is failure or there is complication post thrombolysis, then shift to a PCI center. That way, you will be able to preserve the PCI center for a more complicated case and cause lesser harm to the patient by shifting, because shifting will take a long time, much longer than the usual 90 minutes it takes, and the vehicles may not be available. Even if he comes to the ER on time, he may not be attended to immediately. So if if the shift is not possible, or if you feel that the patient is okay, not very critically ill, thrombolize in the peripheral center only. So what do we do in our hospital? So we have already set up a system by which we organize this. The ambulance is brought, the patient brings in the ambulance, is received in a PPE2 kit patient. Sorry. The patient gets taken to the ER, where BP, pulse and ECG are taken. The ER doctor conveys to the cardiologist about the patient. The nasal swab for 2 nights is taken there only.
Emergency to Capra.
So there's a code green corridor that is produced, which is free of any other people. There is a dedicated lift which is used only for the COVID patients. The patient undergoes a PCI with only the doctor and the one nurse and one doctor and one cath lab technician inside, and they all wear type 3 level of PPE. And post angioplasty, the patient is shifted to a ICU, which is exclusively dedicated to the COVID patients. So the carry home message is that in the acute myocardial infarctions are happening in an ordinary scale, to say the least, and in acute myocardial infarctions in a COVID positive patient is very difficult to treat because of the comorbidities and the other complications which occur, and these people respond to thrombolysis better than PCI, provided it is not an anterior wall MI or it is not an inferior wall MI with a complete heart block. In such patients, you should shift the patient to the nearest cardiology center where there is facilities for PCI. So the take-home message I would like to say is that COVID has its own manifestations for heart. It can come with acute myocardial infarction, it can come with myocarditis, it can come with cardiac failure. They should be dealt with carefully. If the myocardial infarction is stable and there is just low ST elevations, you can thrombolize in the periphery. If post thrombolysis there is a failure, or if there is a cardiogenic shock, or there is a hemodynamic compromise, or extensive anterior wall or inferior wall with complete heart block, he should be shifted to a PCI center for further management. Thank you.
Thank you, Dr. Mahesh. Now, who is going to speak next? Dr. Juliet?
Yes, Dr. Binjo is
Dr. Binjo?
Yeah, I mean,
1 minute, 1 minute. If you
Binjo, I'll be talking from Dr. Julian's laptop.
I mean, now Dr. Binjo will be talking.
I'll be sharing the screen of Dr. Julian and will be common.
So Dr. Binjo Varapalli will be talking.
Yeah, I'll be talking from
because we have forgot to introduce the faculty just before that. Now I will introduce Dr. Binjo Varapalli, did MBBS from Thrissur Medical College, MD General Medicine from Government Medical College Madurai, DM Cardiology from Government Medical College Calicut, 5 years experience, work experience, Government Medical College Calicut 1 year, Westport Hospital Thrissur 3 years, currently consultant Apollo Deluxe Hospital Karveri Angabali. Over to you, Dr. Binjo.
Thank you very much for introducing myself. ഒരു കാര്യം പറയട്ടെ, ഞാൻ തൃശ്ശൂർ IMA മെമ്പർ തന്നെയാണ്, and Thrissur is my hometown.
Okay, thank you.
Can you see my slides?
Yeah, we can see.
Okay, good evening everyone. including my teachers, seniors, and office bearers of Thrissur IMA. The topic for discussion is heart attack, and I won't be going into the deep, but I'll be just overviewing and just revising what we have studied, what we are doing, and certain things which is updates also I'll be just following up. So in my talk, I will just talk about what is heart attack, its symptoms and signs, risk factors, diagnosis, and differential diagnosis of chest pain. And the next part of the heart attack overview, that is the management part, will be discussing by my colleague, Dr. Julian. So everyone knows that the heart is a muscle mass with the size of a clenched fist, and it lies behind the sternum between the two lungs, and it pumps about 1 lakh times a day and around 7,600 liters of blood per day. And we all know that it's one organ which starts pumping from our birth till death, and when it takes rest, that's our death. And what's heart attack? And it occurs when the coronary arteries means that arteries which supply the muscles of heart are getting blocked. And when it is partially blocked, it causes angina, that is a chest pain due to coronary occlusion or chest pain due to ischemia of the muscle. Heart muscle is known as angina. When it is fully blocked, it results in myocardial infarction, and that is what is known as heart attack. And everyone knows the coronary arteries arises from the sinuses of ascending aorta, and mainly there are two arteries arises from the aorta. On the left side, the left main coronary artery arises, which divides into two, that is the left anterior descending and left circumflex. And on the right side, we have right coronary artery. So whenever we get a report like triple vessel disease, that means these are the three main vessels that supply the heart, that is the left anterior, left circumflex, and right coronary artery. If all arteries, including that all these major arteries are having the block, then it is known as triple vessel disease. That we come across the reports from angiogram reports. Or if you are having a single vessel disease or double vessel disease or triple vessel disease. If left main is involved, we will be specifically mentioning left main plus single vessel, left main plus double vessel, or left main plus triple vessel disease. So this is the evolution of atherosclerotic plaque in our coronary, in our arteries. So this type of artery without any normal artery is seen mainly in our first or second decades, and from the second decade itself, the process of atherosclerosis starts in many of our lives or many of our arteries. The first step is the endothelial dysfunction. That means some damage occurs to the inner lining of the arteries, or can occur anywhere, any vessels in our artery, and the atherosclerotic patch may start in the aorta, and when it starts in coronary and progress, it results in ischemic episodes. So once the endothelium is damaged, the fat or lipid profile, lipid which is inside our blood vessel get deposited inside the endothelium, which then results in the cytokines and other release, which recruit muscles from the media and also further lipid cells from the blood to the finally resulting in a plaque-like structure. And this plaque, when it is 40 or 30%, may not have any symptoms. When it grows over 70 or 80%, that only may be present only when the patient is exerting. And sometimes this unstable, when this plaque ruptures due to some risk factor, which is more common in some risk factors like hypertension, diabetes, or anything else, and may result in sudden occlusion of the entire vessel. That results in the signs and symptoms of heart attack, and that is known as myocardial infarction. So coming to the symptoms, everyone knows typical pain, that is anginal pain. Sometimes the patient may not be telling it as pain. Sometimes they'll be describing it as heaviness or tightness or burning pain or pressure, which may be a squeezing like feeling over the breastbone, which may radiate into our arms, jaw, or back. Sometimes the patient may not be having any chest discomfort, only epigastric pain and discomfort or vomiting will be. These are the features which may also present in gastritis, and we may miss the diagnosis of myocardial infarction. So when we are getting a high-risk patient with hypertension, diabetes, other strong family history with epigastric pain or gastritis-like picture, not relieving by other things, always we should think about myocardial infarction as a differential diagnosis, and ECG should be done, which is otherwise we may miss a dangerous which may kill the patient. And it also mainly in diabetic patients may also present without any pain. So the other signs which may present as heart attack are shortness of breath, sweating, nausea, lightheadedness. And what happens in myocardial infarction? As already told, these blood vessels get occluded, and when the blood vessels get occluded, totally occluded, it results in the ischemia. And if ischemia persists, it results in the infarction of the myocardial muscles. And this ischemia and infarction may result in the severe pain in the chest, or which may radiate into the various parts like arm, neck, or jaw also. And the initial period of is very important, because 20% of the coronary artery disease events present as sudden cardiac death, and most of this death occurs in the initial hours due to primary ventricular fibrillation or ventricular tachycardia, or the arrhythmias occurring at the initial periods is the major cause of death. And we should, the most important thing is that when the patient is having symptoms or diagnosed to have a coronary artery disease, it is very important to recanalize or revascularize the vessel at the earliest, and he should be shifted to a hospital with cardiac care at the earliest. If you come across the risk factors, we can broadly divide into modifiable and non-modifiable. And non-modifiable means which are factors which cannot modify, like our age. As we all grow old or as we age increases, the chance for myocardial infarction and ischemic cardiac events are high. And males are having greater rate than women, and the hormones during their before menopause give some protection to women, but the rate of coronary disease after menopause catches to the males after the menopause. And family history is another thing. If the one of our first degree relative is having a premature coronary disease, then we are also having an increased risk for coronary artery disease. What do you mean by a first degree relative? Our siblings, our parents, or children. These are the first degree relatives. And what do you mean by a premature coronary disease? Males having a coronary artery disease or any other vascular events before the age of 55, and females before the age of 65. Then we are telling that we are having a first degree relative, we are having all these things before males before the age of 55 and females before 65. Then we can say that that's a positive for family history. The modified risk factors include, everyone knows, hypertension, dyslipidemia, obesity, diabetes mellitus, physical inactivity, and cigarette smoking. Coming to the blood pressure, this is the slides taken from European Society, that normal is taken as less than 120/80, and systolic blood pressure more than 120 to 129 is taken as elevated. And if the systolic blood pressure is 130 to 139, or if the diastolic is 80 or 89, it is taken as stage 1. And if the systolic blood pressure is more than 140 or higher, or 9, diastolic more than 90, it is taken as stage 2. And if the patient is having a hypertensive crisis, more than 180, or diastolic more than 120, or the patient is having target organ damage, features of target organ damage. So our target is to keep the blood pressure at the lowest. Ideally is 120/80, or at least below 140/90, and if possible less than 120/80. That's a new guidelines which says. And as everyone knows, hypertension can increase the risk of stroke. It also increases the risk of heart disease. It can cause damage to kidneys and eyes, and it can cause impotence, and also cause other various things. Coming to dyslipidemia, the most important thing that we should understand is there is no single target below which we can say the LDL is our target range is in a population. So if someone comes to and asks you what is the ideal LDL or cholesterol level, first we should risk stratify the individual. Then we should tell, or we should tell what is the LDL target for this patient. And this risk stratification is based on basically on whether the patient is hypertensive or diabetes or other thing, whether the patient is having kidney disease. If the patient is having kidney disease, what is the EGFR, and whether the patient is diabetic. If the patient is diabetic, then we should say what's the duration, whether the patient is having any target organ damage. And based on this, we have to categorize the patients into very high risk, very high, high, moderate, and low. And those individuals with having low risk, the chance of cardiovascular events are less than 1%, then the ideal LDL cholesterol level should be less than 116 milligram per deciliter. In moderate risk individuals, the LDL goal is less than 100, and in high risk, then the ideal LDL goal is less than 70, and in very high risk, it includes that those patients already are having a atherosclerotic cardiovascular disease in the form of myocardial infarction or any acute coronary syndrome, stroke, peripheral vascular disease, or a documented heart vascular disease by any imaging or angiogram. All these things can, or diabetic patient with a target of damage, all this belongs to very high. In these individuals, the ideal LDL target is less than 55. And in very high risk, that patient is on having more than one event, cardiac event, or the patient is having a cardiac event even on medications or on target LDL levels, then we should keep the LDL levels less than 40. That is what European Society guidelines says. And as we all know, what can bring down our cholesterol levels? Our diet is very important. Regular exercise, stop smoking, reduce alcohol, and proper medications. And it's very difficult to convince the patients for high dose statins for a longer time, but we should be able to tell the benefits, and we should be able to tell it's less, it can cause only less harm, and more we get to the advantages are there. Coming to the obesity, ideally healthy individuals have an BMI of 18.5 and 24.9, and if the BMI is between 25 to 30, it's taken as overweight, and obesity is more than 30. In Indian scenario, and slightly different version, and normal is taken from reduced to 25 to 22.9, and between 23 and 25 is taken as overweight, and if obese more than 25. Another important thing which can cause the obesity is the waist circumference, and we should be always give advice to the patients regarding the ideal body weight and the advantages of it, and we should always try to keep them at the optimum body weight. And as everyone knows, coming to diabetes, it increases the risk of coronary disease by 2 to 4 fold, and there is high chance for asymptomatic coronary disease in those with diabetic. So diabetic patients may present with painless acute myocardial infarction, arrhythmias, congestive heart failure, and if they come with any of these complaints, the duration of hospital stay is more when compared to non-diabetic patients. And in majority of the diabetic patients, the cause of mortality is maybe in around 60%. It results from cardiac event. And coming to physical activity, the recommended is moderate to intense physical activity. That means 30 to 45 minutes, at least 5 days of a week is recommended. So total accumulation moderate intensity activity or exercise should be done at least 150 minutes in a week. And you can do more time, and it's also good for health. And coming to smoking, everyone knows that it increases the blood pressure, it contributes to atherosclerosis, it lowers the good cholesterol, that is HDL. And if you quit smoking, the 1 year of quitting CAD risk decreases, and within 2 years it reaches almost that of a non-smoker. And female smokers have a higher risk than a male smokers. So quitting smoking is very important. Coming to alcohol, there is controversies, but only in small amounts it acts as a vasodilator. There is no doubt that in large amounts it acts as vasoconstrictor and adds to the caloric intake, and it's not healthy if you are taking higher doses of alcohol. The good and bad effects of alcohol are divided by a very fine line, so we should be very careful about this. And we know alcohol kills brain, it damages liver, it increases the blood pressure, it can affect the heartbeat and can result in arrhythmias like atrial fibrillation, and it increases the risk of heart attack. And how can you diagnose a patient with heart attack? And history is very important. Sometimes only history will be there, the ECG, the investigations, everything will be normal. But if the patient comes with a typical pain, then we should diagnose a cardiac event or acute unstable angina. The other things which may help in our diagnosis are electrocardiography, ECG, cardiac markers, the troponins are the gold standard. Echocardiography if you are having some confusion, and in low risk patients with persistent pain, stress test, or coronary angiography may help in the diagnosis. Then coming to if someone is coming to a chest pain in emergency, the reason for this chest pain may be on ST elevation by only 5 to 10%, and 50 to 10% may be having non-ST elevation myocardial infarction, and 10% may present with unstable angina. Unstable angina means there is no significant ECG changes, there is no significant troponin level elevation, but the patient is having a significant disease. And some 15% may be having other cardiac conditions, which I will be explaining later. And half of the patients with chest pain will be coming with non-cardiac. So we should be knowing to differentiate from cardiac from non-cardiac, and in cardiac we should be able to find out which are the causes for acute coronary syndromes. These are the various causes which can present with chest pain in emergency department. The cardiac causes include myocarditis, cardiomyopathies, arrhythmias, heart failure, hypertensive urgencies, the stress cardiomyopathy, or even spasm. Pulmonary also we should think about pulmonary embolism, tension pneumothorax, bronchitis or pleura. Vascular also can diseases like aortic dissection also may come up with chest pain. Gastrointestinal esophagitis or peptic ulcer gastritis. Before we diagnose gastrointestinal disease, we should rule out MI if the patient is having high risk. Other orthopedic musculoskeletal disorders, chest trauma, muscle injury, costochondritis, cervical spine pathologies also may present with chest pain, and sometimes anxiety and herpes or anemia also can present with symptoms. So already we discussed shortness of breath, chest pain, nausea, anxiety, sweating. These are all features of symptoms. Coming to the ECG findings, this is one ECG which we can see ST elevation in anterior leads. That means the V1 to V6 and reciprocal changes in inferior leads. This is one ECG which is suggestive of acute anterior myocardial infarction and requires angiogram and revascularization at the earliest. Otherwise, the patient may develop loss of myocardial muscle and results in low ejection fraction and heart failure later. This is another ECG where you can see the ST elevation in inferior leads, that is lead 2, lead 3, and AVF with reciprocal changes in V1, V2, and V3. There is a patient with inferior valve and along with the posterior valve myocardial infarction. It also requires early revascularization, and if it's not available within the time, with the time span, then we should go for lysis. This is another one. We can see the ST elevation mainly in AVR, also in some amount in V1, and significant ST depression in 2, 3 AVR, 1 AVR, in more than 6. That is something called left main LMCA pattern, left main coronary artery pattern. This can be seen if there is a significant obstruction in left main coronary artery. It can also be seen if the patient is having triple vessel disease or multiple coronary arteries having significant blocks also may present with this type of ECG changes. So he requires early angiogram, and if it may require revascularization either in the form of angioplasty or in the form of coronary bypass. This is another ECG where you can see a significant T inversion in anterior leads. If you see the T inversion is V1, V2, and V4, V6, and this pattern, if the patient is having chest pain, you should think about a significant lesion in left anterior coronary artery disease, and these patients may present with acute anterior valve myocardial infarction in short time. Sometimes the first ECG may be Wellen, is a Wellen sign, and next ECG after 5 minutes may present with acute myocardial anterior valve myocardial infarction. So if you are having a chest pain and this type of ECG, it should be given due respect and it should be referred for a early revascularization. Coming to the cardiac markers, and high sensitivity troponin is the gold standard, and there are different algorithms where we check at 0 hour and 2 hour or 0 hour or 3 hour for an early rule in or rule out. Then coming to the CKMB only done if troponin is not available, and other markers like BNP or NT-proBNP can be done, which help in risk stratification and not for diagnosis. Coming to the troponin level, if the patient is having an ECG ST elevation, there is no doubt for that it's an ACS. It should be taken up for a coronary angiogram at the earliest or shifted to a hospital with a cath lab facility at the earliest. If the patient is having symptoms and we are having doubt, then we should check the high sensitivity troponin at 0 and 1 or 2 hours. And if there is no it's negative, and if there is no change in the troponin level, if it's a high sensitivity troponin, then we rule out acute coronary syndrome. And these patients can be taken up for angiogram or CT, coronary angiogram or stress testing if we still suspect acute coronary syndrome. If the patient is having a 0 or 2, if you are having an increase in the troponin levels, then we should rule in and should be taken as acute coronary syndrome. And depending on the patient's symptoms and other vitals, we should think about angiography at the earliest. This elevation of troponin doesn't mean myocardial infarction always. It means there is some damage to the myocardial cells or muscles, and it can be caused by tachyarrhythmias, heart failure, hypertensive emergencies, critical illness like shock, sepsis, or burns, myocarditis, stress cardiomyopathy or Takotsubo syndrome, valvular heart disease or stenotic lesions like aortic stenosis, aortic dissection, and even pulmonary embolism or pulmonary hypertension with RV dysfunction or renal dysfunction patients also can present with elevated troponin. So whenever we are getting a troponin minimal elevation, or we should think about other causes also, and all these things should come in our mind. I'll be stopping this and giving to Julian after just describing the universal definition of myocardial infarction. Detection of an increase or decrease in cardiac biomarker, preferably, or the ideal thing is high sensitivity troponin at least one of the following, and at least one of the following. There should be symptoms of myocardial ischemia or no ischemic changes. It can be ST elevation, ST depression, or formation of new Q wave, of a pathological Q wave, imaging of evidence, that means echocardiography showing a loss of myocardium or a new regional muscle abnormality, or coronary angiogram showing thrombus. This is the universal definition. So we should be able to find out the patient presenting with casualty, with chest pain, with either in the ECG markers, or if not helping with all this, it should be other imaging modalities. So once we diagnose myocardial infarction, the management part will be discussed by Dr. Julian.
Thank you.
Yes, sir.
Dr. Binjo. Now, before Dr. Julian starting his introduction, over to you, Dr. Pawan. Pawan?
Yes, thank you, Dr. Joy. Thank you, Joy, sir. Let me just interrupt in between the talk. Sorry to say that we forgot to introduce our speakers of the day because we got their details very late. Let me introduce Dr. Mahesh Nalin Kumar, Dr. Surgeon Commodore Dr. Mahesh Nalin Kumar, VSM, who held the strategic operational leadership and instituted the largest interventional cardiology program in the armed forces, which is one of the busiest centers in the country, doing more than 2,800 procedures. He introduced the new cutting-edge modality and treatment as per the international standards among the top operators in India for angioplasty, for cardiac imaging, as well as for intracardiac pacemakers, etc. He's examined at many universities, including the National Board, and he has 26 articles in international and national journals. He was the HOD of cardiology and medicine in INHS Ashwini, Mumbai. And he also worked at the base hospital in Delhi Cantonment and Army College of Medical Sciences at Delhi. He did MBBS and MD from AFMC and did DNB Cardiology from Amrita Institute of Medical Sciences, Cochin. He is a fellow of American College of Cardiologists and fellow of European Society of Cardiology. I welcome Dr. Mahesh Nalin Kumar to the meeting. Now I also introduce Dr. Julian and Dr. Binjo Varapalli. Dr. Julian, he did his MBBS from Thrissur and MD from Bangalore Medical College and DM from Calicut. He worked at Calicut Medical College and also at Westfort Hospital, Thrissur. Now he is presently at Apollo. And Dr. Binjo Varapalli, he too did his MBBS from Thrissur and MD from Madurai and DM Cardiology from Calicut Medical College, and presently working at Apollo Hospital, Kochi. I welcome you all to the meeting, and let's continue the session.
Okay, I'm Dr. Julian. Thanks. I'm speaking from the Apollo studio. Thank you, distinguished members, the president and the secretary, for giving us the opportunity to present. And the third part is acute coronary syndrome management. Hope you can see the slides. Can you see the slides, please? Hope you can see the slides. Okay.
Thank you. Slide is there. Apollo Kochi.
You cannot see the slides.
No, slides on the left side you can see.
1 second, please. 1 second. Screen. What about now?
Oh, now it is okay.
Okay. So I'm going to, I think we are getting late. I'll make it a bit fast. I'll be dealing how we practically what the cardiologists do to patients presenting with acute coronary syndrome. So initially the ACS management to divide, it's basically divided as STEMI, ST elevation MI, where the management is medical and invasive. Medical, it is dual antiplatelet therapy, which is known as DAPT, and statin with fibrinolysis, and invasive, it's primary angioplasty. And in NSTEMI and unstable angina, again, the medical management is heparinization of the patient, and again, DAPT, which is dual antiplatelet therapy, and statin. Invasive management is done for patients immediately when there are significant STT changes, which are dynamic in nature, and recurrent pain, heart failure, and arrhythmia. Otherwise, these patients can go for an elective procedure next day. So this is a very busy slide. It is giving the revised concepts, and I'll be telling in detail how what are the changes that has happened from 2012 to 2020. The new concepts give a very importance to strategy, and also how these patients should be dealt post-operatively, and what are the time limits for routine opening of an infarct-related artery, and how an ECG should be taken, and how what is the time frame for angiography after fibrinolysis and in a PCI K-pool center. So these are the updates in short. The complete revascularization is a favorable in cases of cardiogenic shock. That is, first what we do is that the culprit vessel or the vessel that is involved in the myocardial infarction is dealt with. In the same angiogram, if there are other lesions, it is dealt at an elective date the next day or the day after once a patient stabilizes. But in cases of cardiogenic shock, complete revascularization, that is, all the blocks are removed at the same setting. Oxygen, when to be given? If the saturation is less than 90%, we give oxygen, and low molecular weight is always better than unfractionated heparin. The dose of tenecteplase, that is tenecteplase, these are known as a bolus fibrinolytics. Earlier we used to use streptokinase and urokinase. Now it has been shifted to tenecteplase, retiplase, and alteplase. And in tenecteplase, we reduce the dose in patients more than 75 years of age due to risk of intracranial hemorrhage. Now, as earlier discussed by Dr. Binjo, lipid lowering is very important in cases of cardiovascular disease, and the guidelines tell us to keep it as low as possible and to keep the LDL levels to less than 70. Pardon me for the slide, it is to be kept less than 70. You can do whatever on earth to keep it less than 70. First is lifestyle modification, second is drugs, use statins, and the latest PCSK9 inhibitors like evolocumab or PCSK, which are a bit expensive, but this lowering of LDL definitely helps the patients. Then there are new antiplatelet agents. Earlier we used to use clopidogrel and ticlopidin. Now we are coming to newer antiplatelet agents like ticagrelor, prasugrel, etc. Ticagrelor is known as from the brand names Brilinda, Axer, etc. in the market. So everyone should have an idea what this drug is. And this drug is used earlier we used to say that we use a dual antiplatelet therapy up to 1 year, but now there's data saying that it can be used up to 36 months. Now, what is the time limit for opening an infarct-related artery? If a patient comes with chest pain, and it is definitely, if it's an anterior wall myocardial infarction or a posterior wall or an inferior wall myocardial infarction, if we diagnose it's a STEMI, it should be opened in 12 hours. And if the pain is still on, it can be, there is an indication to open it up to 48 hours. But beyond 48 hours, it is harm or it is not required. Now, the time limit for CAG. Now, there is a new guidelines telling that the after the fibrinolysis, these patients, all patients need to undergo coronary angiogram within 24 hours. Now, maximum time to take ECG. Now, this is a terminology called FMC, or the first medical contact. It's the first medical contact is defined as a place which has an ECG machine and there's a doctor which can diagnose myocardial infarction. So the time to take an ECG is 10 minutes. We all know that time is muscle. We need to be very strict on this. We need to convey to our colleagues that time is really muscle. We need to do the things as fast as possible. So once the patient reaches the center, ECG should be taken in 10 minutes. And our ECG should be having a defibrillator facility in the casualty. Many a time, as Dr. Binjo said, many a times the most important cause of death will be an arrhythmia, and just a shock can revert this arrhythmia and save the life. Additional leads like V7 to V9 can be taken for posterior wall MI, V3R and V4R for right lateral leads, that is for RVMI, right ventricular myocardial infarction, and routine sampling for serum markers. Like we can do all sorts of markers like BNP and NT-proBNP, etc. But this should not hamper or should not delay in the reperfusion treatment. And opioids can be given to relieve pain and is treated adequately. In the past, very large doses of opioids were used to be given, like 25 and 30 milligrams, but now we give morphine of mainly 2 to 3 or 4 milligrams with phenergan. Benzodiazepines can be given to relieve anxiety. These patients are usually anxious. And this is a timeline that helps you to go across, and this it is very important that we follow the timeline. Time 0, there's a strategy clock on the right side of the image which shows time 0 is a time when the patient reaches the casualty. ECG should be taken in 10 minutes, and decision should be made whether angioplasty or fibrinolysis should be done. Angioplasty, if the patient is a non-PCI center, that is a routine hospital without a cath lab, these patients should undergo an angioplasty within 120 minutes. If not, if you think that this patient cannot be shifted within 120 minutes, and if it takes more than 120 minutes to reach a PCI capable center, fibrinolysis is the strategy. If the patient is in a PCI capable center, then immediately the loading dose of drug should be given, and definitely wire crossing, that is the angioplasty, successful angioplasty should be done within 60 minutes. Now, if this is in a PCI non-capable center and you have decided for fibrinolysis, and if the fibrinolysis should be begun within 10 minutes, and once the fibrinolysis is over, you should assess for the successful nature of the fibrinolysis or not, and shift the patient to a PCI capable center within 60 to 90 minutes. So this is written in sentence. Maximum time from the first medical contact to ECG is 10 minutes. Maximum expected delay from STEMI diagnosis to wire crossing is to be less than 120 minutes. If it's more than 120 minutes, you choose fibrinolysis. Maximum time from STEMI diagnosis to wire crossing is 60 minutes. Maximum time from STEMI diagnosis to wire crossing in transfer patients is 90 minutes. That is, you get 30 minutes to transfer a patient from a non-PCI capable center to a PCI capable center. Maximum time from STEMI diagnosis to fibrinolysis is 10 minutes, and you can assess the fibrinolysis time within 60 to 90 minutes. All the patients who have undergone fibrinolysis should undergo an angiogram within 24 hours. So definitely a patient coming with symptoms of ischemia like chest pain with ST elevation should be treated. That is, a reperfusion therapy is indicated for all of them if they present within 12 hours. And always a primary angioplasty is recommended over fibrinolysis within indicated time frames. If the timely primary PCI cannot be done, the fibrinolytic therapy is recommended within 12 hours of symptom onset. So if in asymptomatic patients there are no symptoms of ischemia, a routine PCI for an infarct related artery, if it's more than 48 hours after the onset of STEMI, it is not indicated. So what we are going to plan a PCI. So what do? We load the patient with aspirin 300 milligrams. We maintain a dose of 75 to 100 milligrams of aspirin daily. We load the patient. As I earlier mentioned, it is dual antiplatelet therapy. We use one drug is aspirin, other is a P2Y12 inhibitor, which either can be clopidogrel, plasugral, or ticagrelor. Clopidogrel loaded if you're planning the patient for a PCI, you should load him with 600 milligram. If you're planning for fibrinolysis, 300 milligram, and the maintenance dose is 75 milligram. Prasugrel, if you load, it should be loaded 60 milligrams and a maintenance dose of 10 mg for the patient after the primary angioplasty. And some patients we give 5 mg for as if they are less than 60 kg of weight, and usually not recommended after age of 75 due to and stroke patients. Next is ticagrelor. The loading dosage is 180 milligrams. Maintenance dose is 90 milligrams BD. These are the drugs which are in the dual antiplatelet therapy. Aspirin on one hand, on the other side you use clopidogrel, prasugrel, or ticagrelor. Heparin, as everyone says, the guideline says the enoxaparin is better than unfractionated heparin. Though both are used, you give 0.5 milligram per kg IV bolus of enoxaparin or unfractionated heparin 70 to 100 units per kg. The other drugs which we use are antiplatelets like tirofiban, abscesimab, and etifibatide, that is during the angioplasty. If the thrombus load is more, or if the patient is not taken loaded with aspirin or clopidogrel, this is the antiplatelet that can be given, and it acts very quickly as it is given IV. In fibrinolysis, it is recommended within 12 hours if the primary PCI cannot be done. If the time exceeds more than 3 hours with symptom onset, always better is PCI. And you have to check, you have a very big list of contraindications, and we need to get a proper history from the patients. And many a time the attenders are anxious, the patients are anxious, and they cannot give an indication. They cannot give the contraindication list here. So these are the various agents that can be used, and the contraindications are also given. If any patient has got any intracranial pathology, that is an intracranial hemorrhage or ischemic stroke or CNS system damage due to neoplasms or AV malformations, GA bleeding disorders, aortic dissection, here these are the indications we can never use them. And in streptokinase, 1.5 million units, that is the previously we used to use, but now the bolus fibrolytic agents like tentiplase, and altiplase, these are single shot bolus infusions. They come as pre-filled syringes, or we just need to reconstitute them just by mixing saline and this agent. It is pretty expensive. Tentiplase is weight based, 30 milligrams if less than 60 kg, 35 less than 70 kg, 40 for 80 kg, and we just give the bolus over 10 minutes and watch for the ECG changes within 60 to 90 minutes. If the ST elevations have settled by more than 50%, we take it as successful fibrinolysis. If not, the patient needs to be rescued, needs to be taken for a prompt angioplasty, which is known as a rescue angioplasty. Now, I would like to briefly tell what we do in a routine angioplasty by a case. So this happened last week. It's a 40-year-old male who is a diabetic and a hypertensive. The family history of CAD was there. He presented with chest pain in our ER. And he was sweating profusely. He had a BP of 90/60 and pulse rate is 110 per minute, and SpO2 is 90% in room air. He's conscious and oriented. His saturation according to guidelines is 90. We put him on oxygen, and his BP was 90/60 and he was having severe chest pain. We suspected him of anterior wall myocardial infarction, and this is his ECG. You can see that there is an ST elevation in lead 1 and AVL, and a very 5 mm ST elevation in V1, V2, V3, V4 and V6, and there are ST depressions in 2, 3 AVF, which are the mirror images of anterior leads. So this is the case of anterior wall myocardial infarction in cardiogenic shock, and with a low saturation. He is in a very sick state. He is going to have an impending pulmonary edema. And so what we do, we immediately take him, the ECG is taken in 10 minutes. We immediately loaded him with ecospirin 300 mg stat, and one of the above that we loaded him with ticagrelor 180 mg, because data says that ticagrelor is far better than prasugrel and clopidogrel. We load the patient with atorvastatin 80 mg or rosuvastatin 40 mg. We secure an IV access, and the emergency people alerted us and the cath lab. So how do we do this procedure? We either do it through the radial artery or we do it through the femoral artery. Actually, we all know that all roads lead to Rome, that all the arteries lead to the heart. And as you can see, the right side, the picture of a human being with his arterial tree. You can see the radial artery. We need to brush up the anatomy. Radial artery, brachial artery here, axillary artery, and then going to the arch of aorta, subclavian artery, arch of aorta, and to the heart. And from the femoral artery goes via the iliac arteries to the descending aorta, thoracic aorta, and again to the heart. Now, where are the coronary arteries located? They are located very close to the aortic valve. I have just zoomed it on the left side. You can see the aortic valve here, and you can see this is the how do we reach these coronaries? We reach these coronaries through a set of catheters. You can see these catheters of different shapes and sizes with different names. These catheters are used to hook the coronary arteries, and how you can see this coronary is hooked like this, and this is the coronary vessels which are coming out of these vessels, and we inject dye to see where the block is, and we remove the blocks. That is, you can see a block as indicated in the picture here. These cylinders with lesion here, we remove the blocks with wire. A wire is passed through the block, and then the balloon, a balloon on the top hand of the page is shown, and it is dilated, it's inflated, and then after that we place something called stents, which are like metallic frames made of platinum, chromium, or various alloys, as you can see in the left side of the picture, and this is used to keep the vessel expanded and prevent recoil. So this is the coronary arteries already. Coronary anatomy is already been described by Dr. Pinjo. There is a left main coronary artery which divides into left anterior descending and left circumflex. The right coronary artery on the other side. I just want to show you an angiogram. This is the angiogram of the patient, of the 40-year-old male that we took. This is the right side of coronary angiogram. This is the right coronary angiogram. See, the right coronary artery appears like a C. It's like a C. This is a C. This long thing is the tube which is used to cannulate the vessel, and you can see the right coronary artery here. Next image is the left side. This is the left coronary system, and this is the normal left. The second picture, which is the normal coronary system. You can see the two vessels dividing here. You can see the two vessels dividing from the left main, and in this patient, this is the coronary anatomy of this patient, and you can see that the vessel is this is the left main coronary artery. It divides into two vessels. This is the left circumflex artery, and this is the left anterior descending artery, which is abrupt cutoff. There is an abrupt cutoff here, and this is the diagrammatic representation. This is the left main coronary artery. This is the left anterior descending artery and circumflex, and it's an abrupt cutoff here. So, and this is another view of the same vessel, seeing that there is a cutoff from here. The left circumflex artery is normal. So what we do, we put a wire across that vessel. We dilate the vessel with a balloon, and after the balloon, you can see that in the second image, you can see that the one which was abruptly cut off is opened, and the vessel flow is re-established. This is known as wire crossing. Once the wire is crossed across the lesion, the vessel opens up and the perfusion is maintained, and the craving heart muscles get blood supply. So then we put something called stent. The first image shows two markers here. This is the stent, and the stent is inflated and is positioned. And we check after inflating the stent, you can see that the flow is re-established in the coronary vessel. This is such a big vessel which was absolutely cut off. Multiple views are taken, and we have successfully recanalized the LAD. And once the procedure is done, we remove the sheath after the radial or the femoral sheath after 4 hours. We continue dual antiplatelets and statin. We may continue heparin according to the thrombus burden. Echocardiogram is done to see for regional wall motion abnormality and LV function. And what we are aiming to tell is that as early as how fast you can do the reperfusion, the better you can save the muscles, and this prevents the patient from going into severe LV dysfunction. When ejection fraction is less than 40, we start these patients on AC inhibitors and ARBs. Beta blockers are given for all patients to save them from malignant arrhythmias, and also it decreases mortality. We manage comorbidities like dyslipidemia, diabetes, and hypertension. If everything is fine, we shift the patient to room next day, and we monitor the pulse, BP, respiratory, urine output in the hospital as long as the patient is in hospital and everything is well. We discharge the patient on day 3 to day 5. So how long do we continue the drugs? Post angioplasty, aspirin is indefinitely continued. Clopidogrel, ticagrelor, and prasugrel should be given for 1 year at least. Anticoagulation is considered in cases of atrial fibrillation, LV thrombus, and severe LV dysfunction. Bleeding risk versus thrombosis risk should be weighed and drugs given accordingly. So thanks for this wonderful presentation. And I can also see, I am also an IMA member, IMA Thrissur member, and I can see a lot of familiar faces, my teachers, my colleagues, respected President sir and the Secretary sir. Thank you for this opportunity. Lastly, I would like to share this image. This is a path turning image. This is the picture of Dr. Andreas Gramsci. He is the father of angioplasty. He's a German, and he was explaining the first angioplasty in 1976 in an AHA conference. And in that conference, the corridors or near him, there were actually no people and only very few people there, curious onlookers there, listening to what he said. This has revolutionized cardiology like anything, and for 30 years, this new treatment like angioplasty definitely has served a lot of people in saving lives and monitoring. Thank you.
Thank you, Dr. Julian, for your presentation. Screen sharing disabled. Screen sharing disabled, Dr. Julian.
Stop sharing.
Okay, thank you. Any questions? ആർക്കെങ്കിലും എന്തെങ്കിലും ചോദ്യങ്ങൾ ചോദിക്കാണ്ടെങ്കിൽ ചോദിക്കാം. അവൻ ചാറ്റ് ബോക്സിൽ എന്തെങ്കിലും ഉണ്ടോ? ഡോക്ടർ സന്തോഷ് ബാബു ഒരു ക്വസ്റ്റ്യൻ ചോദിച്ചു. What is the rationale of continuing DAPT for more than 6 post MI?
Okay, sir. Santosh Babu sir has given a question. What is the rationale for continuing dual antiplatelet therapy for more than 6 months post MI? So what is happening once what is happening in myocardial infarction is that there is the intact endothelium has ruptured. The intact endothelium has ruptured. There is a wound there, and it exposes the sticky part of the vessel to the blood. There is a continuous process of, there can be a process of thrombosis again and again. So the aspirin will not only suffice, we need to give the aspirin along with clopidogrel in such patients. The stent is just a metallic frame. It just prevents a recoil of the vessel. It does not plaster it does not seal the wound just being formed.
Usually, in a case of simple angioplasty with less risk or single stent and stent length is less, with newer third generation stents, 6 months may be adequate. But if you are using a stenting in a long lesion, or if you are using multiple stents, or if you are using a stenting a vessel with less diameter, the chance for reinfarction or further progression of disease is high. So we should risk stratify the patient and decide whether to continue the dual antiplatelets for more than ideal. Now the guideline says it is 1 year, and if the patient is having high bleeding risk, we can stop dual antiplatelets after 6 months. So we should weigh regarding whether the patient is having high ischemic risk or whether the patient is having high bleeding risk, and decide the duration of dual antiplatelets.
I agree that there have been newer articles which says that we can stop DAPT at the end of 1 month, and they have not been ratified. We are still waiting for finer studies to come out. Maybe in a very few cases, as Binjo said, very low risk cases, we may be able to withdraw DAPT as early as 1 month, but the few pilot studies have come out. We are waiting for the confirmatory studies, double-blind trials to come out.
What is the position of drug-eluting stents currently?
There is only position for drug-eluting stents. There is no position for bare metal stents unless the artery is really, really big, more than 5 millimeter, because that is the largest size of the drug-eluting stent we have. 99% of the drug of the stent usage across the world is drug-eluting stent, and as days pass, they are making it more and more sophisticated. Less of polymer, better ways of delivering drug, less neutral metal, and there is some revision and some upgradation going on every year. Right now, drug-eluting stents are really running well and giving a run for the money for bypass patients. I mean, CABG versus drug-eluting stents. The studies show excellent results so far.
Which statin you prefer, rosuvastatin or atorvastatin? So, if so, why?
Julia?
We have lots of data on atorvastatin, and for myocardial infarction, for myocardial infarction, we have lots of data. When you consider atorvastatin and rosuvastatin, atorvastatin has a lot of studies, but we can use either of them, atorvastatin or rosuvastatin. The dose is very important. In myocardial infarction, we need to keep the LDL to less than 50% of the previous value, or we need to keep the, as I earlier said, to keep the levels very low. So in order to keep them very low, only two potent drugs, that is atorvastatin and rosuvastatin, are the only capable ones which can reduce the LDL to very low levels. So we need to use, even the dose is also very important, 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin, or 40 milligrams of atorvastatin or 20 milligrams of rosuvastatin. These are the doses which is recommended to keep the LDLs low.
There are two peculiarities for triglycerides. One, in Keralites, we find triglycerides to be very high. In alcoholics, we find triglycerides to be very high. So if you're a Keralite and an alcoholic, you can be rest assured that your triglycerides are very high. So in addition to high dose of statin, we may end up giving them a fenofibrate, which also is known to have a combination and reduce the triglycerides. Triglycerides independently may not be of any consequence unless it is above 400, where it can cause coronary artery disease as well as pancreatitis. But triglycerides in the setting of a raised LDL becomes a nuisance value. So we have to bring it down specifically after acute MI. There is also another drug called ezetimibe, which can be given along with atorvastatin and is known to, in addition to being reducing LDL, may raise the HDL. It has been shown in some studies. So rosuvastatin and atorvastatin are the cornerstones. The add-ons are, for triglycerides, we add on fenofibrate, and for HDL improvement, or in those people who are not tolerating too much of statin, you can add on an ezetimibe, which can be of help.
Cost-wise, what is the package of your coronary packages for acute coronary syndrome? With intervention and without intervention?
Difficult question. So it varies between 1.1 to 1.4, depending on what additional things that we have to use. It is competitive. I mean, we in addition to that, the management might give something extra. But 1.1 to 1.4 is the average going on for a acute coronary syndrome who has been tackled as an emergency.
Any more questions? ആർക്കെങ്കിലും എന്തെങ്കിലും ചോദിക്കാനുണ്ടെങ്കിൽ ചോദിക്കാം, ഇല്ലെങ്കിൽ നമുക്ക് വൈൻഡ് അപ്പ് ചെയ്യാം. Dr. Santosh, finished? No more? Then I invite Dr. Pavan Madhusudan.
Yes. So let us close the general body meeting and the CME session. I hope we had a wonderful meeting today. Thank you, Dr. Joy Manjila, for presiding the meeting, and extending thanks to Dr. Gopi Kumar and Dr. Jane Chiman, our State Secretary and State Joint Secretary, and special thanks to Apollo Hospital for helping us organize today's meeting. Thank you, Dr. N.K. Mahesh. Thank you, sir, for joining us and giving us a wonderful talk. And we are very happy that we have got such beautiful facility very near to our town. And extending thanks to Dr. Julian as well for joining us today's CME session. And thank you all the participants and the audience, and hope to see you all for the next meeting. Thank you all. Good night.
Thank you.
Thank you, Joy. Very good session. Prakash.